For your ears only for the week of August 31st, Labor Day, and the start of our final month on air, much of it down memory lane, I'm David Alpern, now with Melissa Exelberth from our August 10th broadcast.
We think that the data are not as accurate as we would like. There may be cases counted as Ebola that are not, and there may well be many cases not counted that are. The lack of treatment facilities, the lack of laboratory facilities make it so that the data coming out, it's kind of a fog of war.
The company is trying to scale up on the production. It's difficult to produce these particular types of antibody cocktails, and it's not at the level of being able to mass produce.
The battle against an unprecedented epidemic of deadly Ebola virus declared a global emergency by the World Health Organization last week is hampered on multiple fronts. Inadequate public health services in affected countries hamper both treatment, such as it is with no proven cure, and reliable information about how the disease is spreading, as U.S. Centers for Disease Control and Prevention Director Tom Frieden testified on Capitol Hill. Distribution of an experimental drug being tried on a pair of American medical missionaries, now back at Emory University Hospital in Atlanta, is limited by production difficulties, not to mention the normal need for testing safety and effectiveness over time, as noted by Dr. Anthony Fauci, director of the National Institutes of Health.
While U.S. officials repeat assurances that an Ebola epidemic here is not likely, it turns out that Emory is only one of 4 hospitals in the country with facilities best suited to deal with the disease. And most health facilities don't even have guidelines on how to prioritize the resources they do have in case of such an outbreak. Boston Globe reporter Deborah Kotz surveyed the domestic medical deficiency for a story last week, and for your ears only, she joins us now to say more. Welcome to the program.
Thank you for having me.
First, what are the most important facilities at Emory that made it the place to treat the 2 American missionaries, even before an experimental drug came in from San Diego?
It has a special infection control unit that is staffed by people who are specially trained in dealing with infection control with these kinds of deadly infectious diseases. So these patients came in, they were fully gowned, completely covered so that the patients themselves, you weren't able to touch them directly. They brought them into these very isolated rooms. When doctors went in to examine them, obviously they would be completely gowned up. And when they left the room, importantly, they would be able to disinfect anything that came out of that room. So they weren't bringing any of the germs outside the room. That was extremely important.
Even if a hospital had such resources, you say it could easily be overwhelmed by demand in an epidemic, especially if it had no firm guidelines on who should get the benefit of them.
Well, it's a really great question, and they really don't have firm mandatory guidelines on the federal level that say this is who we should treat first. That said, the Institute of Medicine and the Centers for Disease Control and Prevention both came up with these recommendations for, looking at the flu epidemics. And so that is something we are familiar with as opposed to Ebola, and saying, in the case of a deadly flu epidemic, how will you decide, for instance, if you have a limited supply of ventilators to keep people with an acute lung failure breathing? How do you decide which patients should get those ventilators? And what they recommended was that you should sort of be giving a priority to the people who are keeping society functioning. Potential vaccine manufacturer, you might give it to police officers or the military force over women and children, for instance, and that's something that's seen as potentially controversial.
But experts you spoke with said some local doctors and hospital officials might find it hard to ignore those we generally think of first: pregnant women, children, the elderly.
Absolutely, and there's an argument to be made to be giving treatments to the sickest individuals or to people who are at risk for being the sickest. For instance, in the H1N1 outbreak, pregnant women were getting far sicker when they were getting infected with the flu virus than the general population, and also potentially putting their baby's health at risk. So there was a priority to get pregnant women vaccinated. So, a lot of this stuff is sort of done on the fly because you don't always know what you're dealing with, and that's why some ethicists were telling me that it's difficult to really set firm rules in place because every infectious disease outbreak is different.
An avian flu outbreak in 2006 led former Governor Mitt Romney to propose a special stockpile of resources. What was his plan and what happened to it?
He suggested and asked legislators in the state to appropriate $36.5 million to stockpile extra hospital beds, extra breathing machines, doses of medication like Tamiflu in the event that there was a flu outbreak. But his request was turned down by state legislators, and I don't think there are any requests in the pipeline or any plans in the pipeline to really implement this.
What do you think about calls to reduce testing time and expand the availability of experimental Ebola drugs? ZMapp from that firm in San Diego and AVI-7537 from Sarepta Therapeutics in Cambridge, not far from Boston.
Obviously, it's hard to argue with calls like that. You certainly want to get any potential treatments out there quickly into as many people as possible. The question is, it's not just a matter of financing, because I think there probably are folks who are willing to finance this, but it's a matter of, first of all, logistics. These drugs are grown on, at least ZMapp is grown in a tobacco plant, and that requires the plants, so you have to get tobacco manufacturers to provide those plants and the time to grow it. It's a complicated process. The other big question mark is just, how safe and how effective are these drugs? They have not been tested widely in humans at all. I mean, basically only these two people, Americans, who are being treated now in Emory, have gotten this drug, and they seem to be doing better, but it's hard to say whether they're, stabilized from the drug or from getting really good treatment. One big factor in Ebola, whether people survive Ebola or not, is how when the disease was caught, how good their treatment was, whether they were well nourished before they got this virus. So it's hard to say how it would do in a poor population in Africa.
And what about the questions we heard at the African Leaders Summit in Washington about why the experimental drugs that do exist are being kept for Americans back in America when the need is so much greater, where the epidemic is running out of control? Should there be an exception for that whole area?
I think that's a great question. I think it's, there are a lot of questions as to, why were these two American aid workers treated before other people, the residents in the population in these countries. And I think that, part of it, as Dr. Anthony Fauci had said, that, part of it is logistics. They were able to get these medications to these doctors. The doctors were in the hospitals. They were already being treated. They could transport it there. There was a sense that, these are American companies and they would like to treat American patients first, and we can argue about the ethics of that. But I also saw some interesting ethical issues raised today as well, that they were saying that if they had given these experimental drugs to the African population and these drugs had failed miserably, then there may have been critics who were saying, you're using us as guinea pigs. Why don't you test this in your American population before you test it in Africans? Why should we be your guinea pigs? And there's a lot of distrust of the medical system in African countries because, rightly or wrongly so, a lot of Africans have not gotten great medical care, and there have been some forms of experimentation on these populations where they say, do we really trust you to be giving us something that's experimental? And again, the question is this drug going to do more help than harm? If you give it to a mass population without actually knowing the safety risks, how do we know that we may not be killing more people? So it's an interesting ethical question. And when you have a disease that's so deadly as Ebola, it's difficult to say why not, if you have any kind of promise of a hope of treatment when there is none, why not try this out in a widespread population?
Boston Globe health reporter Deborah Kotz from our August 10th broadcast. Within a week, there were reports that hospitals nationwide were hustling to upgrade resources for dealing with Ebola, but serious debate broke out over CDC guidance that full moon suit protection was not necessary. The World Health Organization decided experimental drugs could be administered more widely in West Africa, and ZMapp was given to 3 infected African doctors in Liberia. A Spanish priest who also got it later died. Next, from David to Goliath over Gaza, for your ears only.